Thanks, Professor Laura, for the presentation, and thanks for the organizer for the invitation to this relevant symposium. And thanks for another personal engagement, for me important, because Pavia is the city, the birthplace of my father. So today is the way to remember him, and so a special thank for invitation. I'm not an expert in language disorder and linguistic or in, but I'm a clinician, and I investigated some aspects of schizophrenia psychopathology, among them disorganization. So the title of my talk is Disorganization Dimension in Psychosis, especially in first time schizophrenia. First, I want to thank all group members of the Parma program, in particular Lorenzo Pelizza, the director of this program, for supporting all this area of research. So, why did we decide to investigate disorganization, mainly psychosis, and specifically in first stages of schizophrenia? Because, in our opinion, disorganization remains the crucial psychopathological dimension, close to the core of schizophrenia. In his unitary theory of schizophrenia, Bologna stated that I call the mezzo-precoce schizophrenia because, as I hope to demonstrate, the splitting of the different psychic functions, the spectrum, is one of its most important characteristics. And he proposed the theory of association as the central mechanism underlying disturbances in thinking, in thought and speech, but also in motivation and affective expression. Not only in thought. Okay, this is an important concept. Losing ego association in Bloyler's ideas is a central symptoms. And from these symptoms derives all the other symptoms, the primary basic symptoms, but also the secondary accessory symptoms. And in particular, among primary basic symptoms, the thought disturbances, so from a thought disorder and allergen, affective incongruence, inability to affect and anti-affect, but also volitional indeterminacy, volition and non-purposeful behavior, and withdrawal from reality, autism and social evolution. Autism, the meaning of God. So, we have other questions. But are disorganization and legacy symptoms related to different pathological dimensions? Or could they be considered two opposite ends or two endpoints of the same unitary dimension, such as two divergent streets? As the severity levels of disorganization increases, psychic mechanisms, underlying thought, affect, and motivation gradually get stuck and block. And the second reason to study disorganization is that disorganization is usually associated with poor prognosis and socio-occupational functioning decline. For a treatment perspective, targeted intervention on disorganization may specifically lead to improve daily real-world functioning of patients and patients' quality of life. So it is important to study it and also the treatment, the possible, the potential treatment. What effective intervention for disorganization dimension, especially at the onset of illness? Unfortunately, to date, most of the empirical research on disorganization has been conducted in patients with both schizophrenia, and studies in early phases of the disorder are still relatively poor. Moreover, most of these investigations are cross-sectional design and lack of knowledge still affect the longitudinal course of schizophrenia and their potential response to specific psychosocial and pharmacological treatments. However, disorganization in schizophrenia has attracted much less attention than positive and negative symptoms. And this relative neglect may be traced back to early models of schizophrenia, the dichotomy, positive and negative symptoms. And the most common psychometric scales for the assessment of schizophrenia, psychopathology, PANS and SAPS, by Andreas, maintain the disorder conceptualization. These scales and their main statistical dimension resulted from factor analysis, including the disorganization domain, did not originally develop for examining disorganization and schizophrenia, and are composed of items and specifically centered on disorganization symptoms. So, most suitable scales for assessing disorganization features in schizophrenia are needed. So, the aims of our research to investigate the longitudinal stability of disorganization in young patients aged 12-25 years with the first stage of schizophrenia treated within an early intervention of psychosis program across a 2-year follow-up period, and examine any significant association of disorganization with schizophrenia symptomatology, functional, sociodemographic, and clinical feature, as well as with the specialized treatment component of our program across the follow-up. The setting, the prep program is not a cream for really the scene for due to baby diaper, okay? But it's a Parma Psychosis program. Okay? Parma is a city of Parmesan cheese, of Parma ham, and so on. So important is that Parma, the prep program is not a standalone and centralized service, okay? But is a diffuse infrastructure implemented in all adolescents and adult mental health care service of the Parma Department of Mental Health in Northern Italy, okay? In each services, there are professionals specifically treated in IEP paradigm and in interventions due to a model that is inspired to AP paradigm, okay? The prep program is a real world, non-academic setting, primarily engaged in the identification of optimal clinical care pathways in standard public community mental health services within national health service, okay? It's not a research trial. This model is spread in all Department of Mental Health in the Emilia-Romagna with the same model, okay? The instruments are the two scales in PANS and GAF, and these instruments were administered by trained prep team member, both at baseline and every 12 months during the 2 years follow-up period. We clustered PANS items following the 5 main dimensions proposed by Schaffer and Lazzi in a range of analysis on PANS factor structures. Positive symptoms, negative symptoms, disorganization effect, and resistant activation excitement. Specifically, the disorganization dimension includes 8 PANS items. 3 are related to the language, concept of disorganization, difficulty in abstract thinking, and certified thinking, but there are also items not specifically related to the language. Disorder, mannerism and posturing, disorientation, poor attention, distortion of volition, and propagation. 159 patients were recruited from January 2013 and December 20 and June 2019. At baseline, the PANS disorganization dimension had a significant positive correlation with all PANS factor structures and with a lack of judgment inside item scores, but the statistically strongest association was with PANS negative domain. Moreover, it had a statistically significant negative correlation also with the GAF score. Okay? The longitudinal result across the follow-up, a significant decrease in the PANS disorganization factor was found, observed, and the delta between baseline and T2 PANS disorganization dimensions of scores maintained significant positive correlation with deltas in baseline and T2 scores of all other PANS domains, but especially with the negative domain, the strongest association again, works with the negative domain and with the lack of judgment inside item score. Similarly, the delta between baseline and NT2 answer disorganization dimensions will maintain a statistically relevant negative correlation with the delta in the GAF score. So, in impairment in the GAF, okay, in the daily function. Our multiple linear regression analysis results show that exclusively the T1 total number of individual psychotherapy sessions predicted improvements in the delta between baseline and T1 past disorganization. This regression was performed to study the relation between disorganization and the treatment offered in the PrEP program. The PrEP program is a multi-integrated, a multi-element intervention combining psychopharmacology, individual psychotherapy, inspired on cognitive behavioral principle, family psychoeducation, and case management. Okay? Our analysis showed that only T1 in the number of individual psychotherapy sessions have a predictive role to improvement in disorganization, but only in the first year of treatment. If this interesting association was not confirmed at the T2. But most individual psychotherapy sessions were provided in the first year. Okay? Conclusion. Disorganization represents a longitudinal stable index of psychopathology severity. And already at the onset of the illness, and particularly had significant endogenous association with functional deterioration, psychopathology severity, and especially negative symptoms. And so it is, so it supports the theory of Bologna. And some clinical aspects significantly involved in treatment resistance, such as lack of judgment insight. So, longitudinal improvement was predicted by the intensity of individual psychotherapy session offered to first individual in the first year of our intervention. Therefore, targeted psychotherapy intervention on disorganization in young people with early schizophrenia are recommended, and similarly maintaining the intensity of this intervention and their retention in care within specialized IEP as frequent as in the first year of treatment could further consolidate the longitudinal improvement of this organization. It's enough. Thank you for your attention.
Thank you very much. Questions? There.
That was really interesting. I'm wondering how you, and this might be a broad discussion for everybody as well, see the time course of disorganization symptoms, just how much you think, how much it seems like they might fluctuate across an individual over time. How do you think about that with this whole thing?
Disorganization is a complex dimension. In the history of research, disorganization derives from substantially from statistical analysis, then dimension, from factor analysis. Okay, I think that it is important to develop specifically scales, but not only in thought, informal thought disorder, but also in other aspects of disorganization. Disorganization in affect, disorganization in movement, okay? To have a global vision of these complex symptoms. And I think also that it is important to study experience that may underline this disorganization, this manifestation of disorganization that, in our opinion, are the end point, the observed manifestation of disorganization. Under this manifestation, it's important, in our opinion, to study other, probably less, more undefined manifestations, such as basic symptoms, such as abnormality of the self, self disorders, and so on. These probably could better explain also the link between disorganization and these symptoms.
Thank you. First,
Thilo Kircher from Marburg in Germany. So congratulations for setting up this very important first episode service. I have one question regarding the number of treatment sessions. You said the number of treatment sessions correlates with the outcome. So you correct for dropouts, such as
Yes, these analyses are conducted only to people that ended the follow-up.
And so could it be that the most patients drop out from your service? And
The dropout in our service is less than 10% in the first years. Okay?
was another question on the back and then here. Nobody, huh? Okay. Lena.
An easy question. Yes.
In the Parma cohort, but so far my visual imagery was cheese. Now I have to come back for a lap of cream as well. We haven't reviewed on the importance of studying disorganization. You made lots of list of reasons for studying disorganization. One other thing I will add to that is people with disorganization, high degree of disorganization, are probably the most underserved when it comes to clinical trials in schizophrenia. For two reasons. One is consenting is hard and they don't consent and they are excluded. And number two, psychotherapies exclude them because it's hard to engage people with disorganization. So the kind of studies that you do, where it's observational or period, they're very valuable, very important for the people. Thank you very much.
Yes, our study is a study in a particular environment because it is a real world environment. So we study disorganization with these simple scales because these scales are the scales we use in the normal clinical activity. Okay? Thank you.
I have a question. That is, you when showing your sample, you told that you had also patients with first episode at the age of 12.
Yes.
How big was this proportion? Also because this is very, very early schizophrenia that is a sort of different and someone links these two forms of autism. We discussed it with Silvana Galderisi in the last Italian Society of Psychopathology.
The Parma program included also adolescents from the age of 12, yes. It is a difficult problem in clinical, especially the relationship between an adolescent and adult mental service. But in our sample, about a quarter of patients are under 18 years old. And in this subsample of first episode schizophrenia, this proportion is more. So about approximately 15%.
So low, 12?
No,
12 to 14 years?
12 to 18 years.
Yes, but the proportion of 12?
No,
it's
very small. Very small.
Okay.
Yes.
Well, thank you. Pleasure for me to invite for her talk Marta Busia, that works in our unit at San Raffaele University and San Raffaele Scientific Institute, that will talk us about clinical services for psychosis. Is there room for pragmatic language assessment and rehabilitation? This is the typical type